Good morning, casual sages. Thank you for the chance to present today our study, a qualitative study on surgeon-reported barriers and facilitators to the use of risk calculators in emergency general surgery. My name is Claire Rosen. And how do I click here? Oh, this? Oh, this. Thanks. We have no disclosures. Our work was funded by the National Institute on Aging through the NIH. 3, 4, 5, 6. So in modern medicine, we strive for patient-centered care and shared decision-making, in which physicians and patients collectively work to enact medically sound plans in line with patients' life goals and values. Emergency general surgery is a heterogeneous field that encompasses about 7% of annual hospitalizations in the United States and includes operative and non-operative management of often medically complex patients, which leads to difficult decision-making and counseling and communication before deciding what's best to do. Evidence-based medicine combines medical theory, evidence, and practice, and there's been a proliferation of outcomes research and decision-making tools, and I don't think I need to convince a room of surgeons and scientists that we should try to practice evidence-based medicine. However, how we go from being a surgeon or a trainee to assimilating all of the available information, to then having a conversation with the patient and coming up with a shared plan is a little bit of a black box to me and to a lot of the literature. So throughout my career, I hope to open up this box and get a better understanding of what's happening. In this study, we aimed to get a better understanding of how physicians use technology-enabled tools like risk calculators. It was a qualitative investigation of surgeons within a single tertiary care health system, using semi-structured interviews and an inductive analysis within a grounded theory framework. Our goals were twofold. The first was to understand and develop theory around surgeon-perceived barriers and facilitators to using risk calculators in the emergency general surgery setting. And the second was to generate theory regarding the ideal future state of a risk calculator for use in this setting. We included 20 participants. They were all practicing surgeons who take emergency call. We used convenient sampling within our single tertiary care system and purposive sampling to include surgeons with a variety of specialties and years of experience. The interview guide was developed and pilot tested. We performed virtual interviews, which were then transcribed verbatim. There I am doing the virtual interviews, just like that. And then for our analysis, we iteratively revised our codebook and found stability reached by interview 10. Interviews were all coded in duplicate with discussion and resolution of any disagreements. And we performed an inductive analysis using constant comparison between codes, concepts, and themes to generate our theory in this grounded theory framework. We approached 26 surgeons and 20 completed interviews. You can see that a little over 50% of surgeons were trauma, critical care, and emergency surgery physicians, and there was a pretty even split regarding years in practice. Regarding some of the concerns that surgeons had about risk calculator use in emergency general surgery, they talked a lot about health numeracy, both from a physician and a patient point of view. One surgeon said, "Data are just statistics. It's a matter of not only understanding the data and the evidence and the risks, but also putting them into a context that becomes meaningful as a communication." Another said, "I think people poorly understand 5% chance of something." Surgeons were also concerned about some of the characteristics of the tool or risk calculator itself, including internal validity. In emergency surgery, risk calculators that don't take into account physiology are tremendously flawed. External validity. Population-level risk doesn't apply at the individual level. And convenience. Risk calculators may only take a few minutes, but in a busy emergency surgery day, that may feel prohibitive. However, they also noted many benefits to using risk calculators in the emergency general surgery setting, particularly around communication, for things like informed consent. You can say to them, well, based on thousands of people who've been in the situation that you've been in, the likelihood of you having to go to rehab after this is whatever. For report building, one of the downsides of an emergent practice is that you often don't have rapport with most of your patients, at least initially. And so those conversations can be challenging, and having some objective data can be helpful. And litigation mitigation. We pull the risk calculator up, do the calculation, and we even put it in the Epic chart with their notes so that it's recorded that we had this conversation and this was the risk. Risk calculators were perceived to have a lot of benefits and pitfalls depending on the clinical setting. So sometimes in medicine and in emergency general surgery, there is a clear best treatment option. Other times, the best treatment option is a little bit unclear, and we're at a state of equipoise. In states of equipoise, the surgeons perceived risk calculators to be beneficial for shared decision-making for complex patients and for modifiable risk factors. One saying risk calculators may influence the surgical plan, for example, anastomosis versus colostomy. However, they were concerned about favored odds and the subjectivity of risk thresholds. You have a 90% chance of dying. It might be, I'll roll the dice on what that 10% chance is. And to somebody else, 90% or whatever might be, I've had a good life, forget about it. Even when a single best treatment option might be clear to the surgeon, risk calculators can help. They can be used as leverage or validation. I actually use risk calculators to talk a lot of people out of surgery. However, there were concerns about patient preferences, physician heuristics, and physician moral distress. It can only make you feel worse about what you're about to do. Regarding the future state of an ideal risk calculator for use in emergency general surgery, surgeons want the input to include the data that they think is relevant to patient risk, and they want a lot of data. They say big data is going to be really useful in being able to prognosticate based on various different things. They want the output to be actionable, patient-centered, and easy to interpret. What I want to know is whether knowing about those risks gives you the opportunity to manage them better and change those outcomes. They want them to be convenient and easy to use. Make some of these tools a little bit more user-friendly, right? I mean, I can ask Alexa, blah, 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 and the Alexa's going to tell me, the information I need. And finally, we need education for both providers and patients. We should teach the clinical application of statistics in medical school. And I hope most of us have had some of that. Overall, surgeons may initially question the data produced by risk calculators in emergency general surgery. But they perceive there to be a lot of virtues to risk calculator use when optimal treatment options are and are not clear. Of course, the ideal risk calculator should be convenient and relevant. But there's a lot that I still want to know within this black box, and I think that future investigation regarding patient perception of risk calculators and direct observation of risk calculator use will be really valuable. Thank you so much for your time and your attention. A huge thanks to my team of collaborators. I'm happy to take any questions here or offline. And if anyone has interest in similar work, I'm always looking for new collaborators for the future.